Safe anesthesia, essential tricks for perioperative complications. I will directly go with the topic, and as our discussion progressed, I will explain why I choose to talk on this topic. There was a one case scenario, a 60-year-old male, diabetic, ischemic heart disease, around ejection fraction is 45%, posted for commando with fibula-free flap, and surgery lasted for almost 10 hours. At the end of the surgery, patient had hypotension, arrhythmias, patient become unstable, but there was a very efficient anesthesiologist was present who immediately assessed the situation. He put CVP, started inotropes, done bedside echo, put arterial line, draw EBG, corrected the whatever acidosis was there, and resuscitation done immediately, and patient managed successfully and shifted to the ICU. Now in second scenario, the same, more or less same patient, 60-year male, diabetic IST with same ejection fraction with free fibula flap, surgery lasted for 10 hours. And post-operatively, patient reversed. There was no any event, awake, obeying command, and shifted to ICU on a TPs. In scenario one, there is excellent management after the complications like putting CVP, co-arterial line, and all those things. While in second, anesthesiologist who monitored that case for 10 hours avoided hypothermia, strictly measured input and output, ABG done electively or proactively after 6 hours, and patient reversed uneventful. If I ask you who is more competent anesthesiologist, and naturally we'll say the one who has taken efforts for more than 10 hours, it doesn't mean that the one who handled scenario one is a non-competent anesthesiologist. He is also a competent anesthesiologist, but who avoided the complication is much more worth rather than managing the complication. So we always say prevention is better than cure, but unfortunately, prevention don't have that much appeal, or many times it's a bit boring, non-recognizable, time-consuming. But curing always looks exciting in medicine, and it has got a measurable response. Means we can show that we have done so many things and patient get cured, and it is even very appealing for the spectator like surgeon and all that. They say that it's very exciting. He is very competent anesthesiologist. And many times preventive person looks maybe non-confident, very meticulous, and but let me tell you, for prevention, you need a plan, you need a thought, you need anticipation, you need a knowledge. So prevention is very, very important. And let me tell you, unfortunately or fortunately, anesthesia is a preventive medicine. We must anticipate the event and we must try to prevent the effect, and that is what we expected to do in anesthesiologist. I usually say that anesthesiologist's role is like a wicket keeper. He is standing behind wicket for almost 50 overs, means for almost 3 hours, 4 hours, 8 hours, 10 hours. He dropped the single simple catch or anything, he is always blamed. So anesthesiologist, the basic role is in prevention. And let me tell you, the good doctors treat the disease, but the great doctors prevent the complication. And that is, we are all great doctors because we prevent the complications. Few tricks that can prevent complications. Now, why I decided to talk on this topic, that I have seen, or we also observe, that there are very common mistakes done regularly and repeatedly. And if we simply change our attitudes towards these mistakes, I think we can, to most of the extent, avoid them or avoid them. And these mistakes are very potentially dangerous. Means if we don't avoid them, we have to face the consequences, or we have to take a lot of efforts to treat these mistakes. So true prevention is not waiting for bad things to happen, but it's preventing things from happening, and it's a plus place. And that is what we are expected to do. That is what a good anesthesiologist expected to do. So the aim of my presentation is not to just remind you, but also myself about this common problem. While preparing this topic, I also wanted to teach myself where we are going wrong, or what are the common mistakes that we are routinely doing. then change perspective for these common problems. And overall, we want to improve the safety and the quality of the care. Let me tell you, when you concentrate on the quality of the care, when your safety becomes a priority, usually quality follows. So safety don't have any other option, but we have to give anesthesia safely to the best of our knowledge and to the best of our outcome. I will not talk much about PAC and all, because whenever this topic of safety comes, first thing is invariably talk about the we should do a very extensive PAC and all those things. But in general, you must look for comorbidities like blood pressure, hypertension, whether they are controlled or not. But apart from that, you must look certain things which we commonly overlook. That I will more talk. Like invariably in PAC form, we don't look at the basic saturation of the patient, which is very, very important. It suggests the respiratory cardio, many times cardiorespiratory status of the patients, and basic RR, respiratory rate. Invariably, as an anesthesiologist, we are always talk about respiration, ventilation, all, but invariably it is overlooked, basic respiratory rate. We ask for effort tolerance, allergy, medication, but as our in last seminar, we must ask about the snoring. It relates with the ventilation, it relates with the intubation, it relates with the difficult extubation. So history of snoring is very, very important. We must do clinical examination, lab investigation, and there are nowadays overall patient load has so much has increased. Now, how to go ahead with this? I think recently ISA has provided us a set questionnaire, and I think we should apply that set questionnaire. We should give this questionnaire to the patients, and they will mention about all these things, and just look at those questions and we come to know about history in great details. So the art of medicine is in observation. So we must observe all his history, vitals, and clinical examination. That is very, very important. Invariably, when you are working in a group, when you are working in a corporate hospital, when you are working in a big hospitals, we see the patients just on the maybe before induction because somebody else has done a PAC. Now, I think this is very, very important when you are inducing that patients, even though our colleague is highly competent, they have done a good job. Still, when before induction, at least you should see some important points like personally check patient file and operation. This is very, very important. I have seen so many times that intubation mentioned as it is normal or easy intubation, but when you ask patient, there are loose incisor, or there is a restricted neck mobility, or there is a history of radiation to the neck, which history might have been missed. So as an anesthesiologist, just before induction, always check the patients. Then always check whether that file is correct, that patient is correct. This is very, very important. And the site, whether it is correct. Recently, we held orthocam. The most biggest worry for me was that a wrong side should not get operated. So we have put 3 filters so that proper side should get operated. Sri Devi's father was operated on in New York hospital on other sides where tumor was not present, brain surgery. So these things happen. So one has to be extremely careful, and anesthesiologist is equally part and parcel of this mischief happens. So one must be careful while doing this case. Now, the careful beginning is avoids thousands of regret, and I think this is very, very important. When you want before induction, you just quickly evaluate the patients, and that is very, very important. Another important thing is check surgical indications and other investigations like maybe sonography, maybe coronary angiography. Now, what a role of anesthesiologist to check USG and coronary. Let me tell you one example. There was an ortho case whose blood pressure was 110, 180 by 100. He is 36-year-old male, and it was a trauma patient. He was in a corporate hospital. All investigations were done, but as I saw his lab, and when I saw his sonography report, there was a mass above the kidney, which was mentioned in the sonography report. Immediately, we suspected it might be a pheochromocytoma, and we defer surgery for 2-3 days, and it was proven to be pheochromocytoma. Or as an anesthesiologist, suppose I wanted to do CABG, I will always try myself to see the coronary angiography of the patient. What is the role as an anesthesiologist? Because if there is coronary perfusion good to the myocardium, if there is collaterals are developed, these are the safer patients. On the contrary, if there is LAD is blocked, there is no CA is also blocked, unprotected left main, or there is no myocardium flush. These are the very, very high risk patients. You have to be extremely careful while managing anesthesia to these patients. So you must see what things are there in investigations. Then our colleague Dr. Deepak usually puts pre-op echo probe, and he has many times proven that putting echo probe can change, can avert the many surgeries, and we get a lot of information. I'm also telling myself to build this habit of putting echo probe to each and every cardiac patients beforehand. So these few steps are very, very important to avoid major complications or major events during the perioperative period. So wisdom consists of an anticipation of consequences, and whatever information we have with the patients, if we go through those informations, that definitely help us to anticipate the consequences. Before taking patients, maybe patient is for local, maybe for small case, always check presence of oxygen, ambu bag, mask, suction, and all these things. This, if you don't follow these 12 golden rules of anesthesia, invariably you will face the difficulties or the complications. There are recent so many cases in the town that has been happened. That also one of the things which promoted me to talk on this topic. This golden rule has been bypassed when patient required ventilation, intubation, proper size tube was not available, suction was not working, laryngoscope was not working. All these things, many a times, as you grow senior, as you become senior, you try to tend to become overconfident. That should not happen. Simple presence of ambu bag in OT many times neglected, but even a best of best ventilator can give you trouble. Today only, when I was managing one case, there was a suddenly ventilator was and that ambu bag was in another OT. These things happen, so you must take care of all these things beforehand. Unless and until you prepare, you will not be able to avoid these complications. So no matter how expert you may be, well-designed checklist can improve outcomes. So always follow this checklist of 12 golden rules, and probably many a times you can avoid the complications. You might be thinking that I am telling very minor points, but let me tell you, they are very, very important. Personally checking patent IV access. Many times we called in cath lab. Everything is going on fine. And suddenly that something happens while inflating the stent and patient goes in bradycardia, or we go to there to give the atropine or adrenaline, we find that the IV access is not patent or it is out. This is very, very common scenario. So when you go for any standby case, always ensure that a patent IV access. Patent IV access is the lifeline of anesthesiologist, and the only worst thing, no IV is a bad IV. So always checking that IV patency is very, very important. I have seen people are doing cases, supramajor cases like placenta accreta, placenta previa, only with a single 20 gauge intracath. When you expect major fluid shift, when you expect major instability, always go with two IV access, always put central line. This is your proactive nature that can prevent the complications. Nowadays, thanks to the present scenario, we have all monitors inside the OT, but many times they are not applied. ECG monitoring for small cases very rarely applied. But let me tell you, many times when patient goes in shock, SpO2 is not coming, we usually think that probe is not working, but patient may be in arrest, patient may be in a severe bradyarrhythmia. So applying ECG is very, very important. More the complex case, more the monitoring. This is simple principle. You upgrade the level of monitoring as the complexity of the case always, and see the monitor with analyzing mind. I have seen people that they many times they are engrossed in on social media, and even if there is a blood pressure is down, there is a frank tachycardia of 130, 140, that they are the eyes are useless when the mind is blind. And one of the reason for this blindness of mind is social media. So you must, even though you are using phone, your mind may get diverted. At least you should try, even if you are using phone, your ear must be on the monitor, and that is how You must inculcate that habit, and unless and until you do that, patient safety will not improve. Now, self-involvement in the case. Personally check certain drugs, wrong spinal drug. This is again a very common problem. Don't ever anytime believe that somebody has taken a spinal drugs for you. Discard it. You yourself must, if you are giving spinal, you must withdraw the drug yourself. Same the condition with relaxant, inotropes, swapping of NTG and noradrenaline. In my cardiac anesthesia career, it happened more than 10 times. Someone has prepared NTG and noradrenaline, and when you give NTG to decrease the blood pressure, it is increasing. This type of are very common mistakes. So you have to be extremely careful while handling these drugs. Without your involvement, you cannot succeed. If you are involved, you can't fail. You have to be extremely careful when using these drugs. Act of commission, adjusting the exact level of spinal is more important than giving spinal. One example, in this TKR camp, we have operated more than 22 bilateral TKR. What we have done is that we first given a spinal and let patients sit for 8 minutes, 10 minutes. We subsequently give the epidural. Now this has changed whole scenario, means that spinal effect was almost up to L1, and rarely patient had a hypotension because drug is gravitated down because we want a very low level for TKR surgery. Just changing this kind of approaches will avoid the hypotension. Very rarely, hardly out of 42 patients on that day, I observed that only 2 or 3 patients had a hypotension who required some bepentramine and all those drugs. Then adjusting the table to match the spinal effect. This is very, very important. You continuously watch how the effect is developing, and as soon as adequate effect is developed, just change the position of the table. Or you can add hyperbaric as well as isobaric solution. Add segmental. Nowadays, this all combinations can be done, and for that you have to be extremely meticulous. Everything takes meticulous planning, and if you do this planning, you can predictably decide the level of the spinal. First 20 minutes are very important. Once you can adjust the good level, there will be a hypotension, there will be rarely complications of spinal anesthesia. And it's so precise nowadays, as recently we have done Operation Sindoor, that BrahMos missile has got a 3 meter of precision. You are firing missile maybe from 400, 300 kilometers. It has got such a precision. Similarly, you should be well versed with spinal anatomy, and you should give the spinal at this particular level so that you should adjust the level as per the requirement of the surgery. So the difference between a good and great is attention to the smallest detail, and that is very, very important. I have seen people are giving spinal for ankle surgery, and patient had a hypotension, severe bradyarrhythmias, liver is going up to T4. That is unnecessary. You are allowing these things to happen, which can be active intervention for long cases, and coordinated team efforts is must. We invariably see that when there is long cases, 8 hours case, 10 hours, input and output management is very, very important. Always see output 1 hourly, 2 hourly, make it a chart. Then temperature monitoring, OT temperature for 8 hours, 6 hours goes at 22 degrees centigrade, 20 degrees centigrade. And in this scenario, naturally patient is bound to become a hypothermic. So we must take active measures to avoid this hypothermia. Always repeat ABG after 5-6 hours. Avoid hypotension. Even episodes of hypotension, there is AKI, there is a post-op delirium. This simple tricks or simply meticulous managing is very, very important. Even someone, when there is a case of 10 hours, maybe 2-3 anesthetists are changing, throat pack kept and removed. There are a number of incidences where throat cap is not removed. So mentioning it, giving proper overview is very important. So the difference between ordinary and extraordinary is that extra has to be done repeatedly, and that is what active intervention is needed. Excellence is doing ordinary things in extraordinary ways, and we have to do all this routine case in something we have to put some extra efforts to bring out the good results. Anticipate. many times we always focus most of the time on difficult intubation, but we must anticipate difficult extubation also. So many times at the time of extubation, unfortunately, surgeon is not there in the OT. OT boys are also relaxed. Nobody is there to help us, and everybody is in a mood to go or finish the case. And at that time, the maximum complications occur. So we have to be extremely careful about extubation, and after extubation also watch for regular, smooth, adequate depth of respiration. This is very, very important. Always keep laryngoscope, laryngeal mask at the time of extubation. They are very important. But these are the, even though this is a very simple trick, but most of the time, if you don't take the care, your patient and you yourself landed in complications. So ounce of prevention is worth a pound of care, but a gram of anticipation is priceless. So if you anticipate this, and if you work on this, there may not occur complication. Nobody is going to compliment you about this, but at least you get a satisfaction. At least you can save your time. As a doctor, always we should have very keen sense of observation, and many times our capacity to auscultate is almost forgotten nowadays. Many times I have seen stethoscope is not there in the OT, but always auscultate after intubation, RT insertion. And let me tell you, whenever you change the position of the patient, maybe for spine surgery prone position, maybe for lateral position for orthopedic surgery or other, you must auscultate this. In this tube going in one lung, maybe right lung, is very, very common, which causes hypoxia, which causes intraoperative desaturation. So auscultating the patient with every change of position is a very good habit, and I think that we must inculcate in our mind. There is only one cardinal rule, and one must always listen to the patient, and that is to stretho. Whenever there is a change in position, when you shift the patient in ICU, you always try to auscultate whether the air entry is good or not. This is a very simple thing, but it helps you to avoid complications. Now, don't hesitate to take the help. I have seen there is a difficult spinal, some senior most fellow is giving, he is not getting, and it becomes a prestige point for him. He gives multiple pricks. And it's very common that even Sachin Tendulkar, Virat Kohli, out on a certain days without score. This can happen. It's not your day that you are unable to cannulate your line, even though you are cannulating it's from last 20 years, and some junior comes and in first prick cannulate. Don't make ego of all these things. This is a very, very bad, particularly for senior people. You are compromising with the safety of the patient. You are compromising with the patients for whom all we are working. Nowadays, there is sonography machine, video laryngoscope. First of all, you make well versed with all this technique, use these gadgets, and they are very helpful. But don't try them in emergency. For routine cases, use these gadgets so that you will be able to try them in emergency. And don't try to make it a prestige point. Just tell somebody, change of hand will increase the success, because somebody who is coming to do this procedure, he is coming with a calm mind and he thinks something different, and procedure occurs. So don't make it to the prestige point. Best doctors are those who know their limits and respect them. And God is a very good equalizer. When you think that you are the boss, he will bring you down. So always remember this thing, and don't make ego for the procedures. Last 2 3 slides about communication. All of us must acquire certain level of communication skills, and unfortunately I think as a anesthesiologist we are not very well versed with this communication skill. Now communication with surgeon is very, very important. Can give a number of examples. There was one case of intracranial tumor. When I saw the MRI of this patient, I was almost frightened, because such a huge intracranial tumor. And in fact, we have talked one day earlier, but I prepare the patient accordingly. I put 4 lumen central line, arterial line, even I try to plan for transesophageal echo for these patients. And surgeon came in the morning and he said, I just want to take the biopsy of this because it's very big. Such things happen. So you should have a good communication with the surgeon, what's going in his mind. Then unnoticed blood loss, especially when person in laparoscopic, you must have very keen observation about unnoticed blood loss. And this is Very important to avoid complications, and you should be vocal if there are instability. That patient should be shifted to ICU, and you should have a close communications. At times he may not like it. You are not his cheerleader. You have to tell some few things that he may not like, but you have to be vocal about these things. So the most important thing is communication, is hearing what isn't said, maybe by patient, maybe by surgeon, or maybe by situation. Now, communication with the patient is also very, very important. In your pre-op round, don't assure TKR patient that surgery will be a painless. Otherwise, many times surgeon assure them your surgery will be absolute painless, but this won't happen in TKR, whatever I have seen. There will be at least some pain. Patient to try to convey this to the patient so he's mentally prepared. Always explain the anesthesia risk. Suppose there is a rhinoplasty, always tell patient that at the end of surgery your nose will be packed and you have to take a mouth breathing. If you don't tell this to the patient, suddenly patient wake up, his nose is closed, he don't know, and he becomes restless. So there is a very important piece of communication that you must do with all patients. Communication with parents, for particularly for children, is very, very important. When a patient is awake, he is crying at the time when you are taking the patient inside the OT. When you took out the patient is a bit sleepy or maybe in sedation. Parents become very much excited or very much they object to this thing. So once you inform that we have deliberately kept him sedated, their anxiety also decreases. Then pre-discussion with team, many times what happens, there occurs surgical complication and surgeon tells you to go and explain this to the relative. So you must explain the things as whatever surgeon is going to explain later. So there should not be dissynchrony between whatever you are talking and surgeon is talking, or otherwise it will invite a lot of trouble. So the art of medicine is entertaining the patient while nature heals the disease. So you must increase his confidence. You must talk with him during the pre-operative visit, and it also gives us a lot of advantage during the perioperative plan. Good medicine is 50% science and 50% art, and that art is communication. So communication has got a very important role. Now, communications within the colleagues or the team is also equally important and mandatory. Let me tell you, clear communication is the oxygen of any teamwork. And if there is no communication, the team suffocates. Always give proper handover. Throat pack is kept. I have faced this and this problem during the induction. Inform the problem, seek the help, discuss your failure, joy within the team, and unless and until you share it, there won't be a solution. It's nowadays everyone is busy. You are working in a team, you are working in a corporate hospitals. Nobody has a time to look at your personal issues, but you should have some friends in the team, in the department, to whom you should share your failures, you should share your errors, you should share your joy, you should share your ecstasy, and that will give you a lot of psychological support, and that communication is very, very important. Now, so the take home message is the complications are often the price of inattention, and patient is the most important of teams. So our efforts or our whole things is patient centric, and that must we should not forget. Let me tell you, none of us is as smart as all of us. We must believe on common intelligence. And I have, as a working in a team, I realized over a period of time that common intelligence is the most important, or it is the greatest things for any team. Checklists are the vaccines of medical air, that one must remember. And the best team is not the one with the smartest doctor, but the one who works cohesively, who works, gives over properly, who inform things properly, who talks clearly, and these are the best teams in the world. Before I finish, I wanted to lastly tell you, good decisions comes from experience, but experience unfortunately come making some bad decisions. And as an anesthesiologist or as a doctor, you must not to learn from your bad decisions, but it is the smart people always learn from the bad decisions of others. Thank you very much.